Good morning, friends. It's nice to be with you in the platform of World Congress of Cardiology and Imaging. And today we are going to discuss a little bit about what does the impact of intensive lowering of LDL cholesterol have on the plaque. So it is not something new. The researchers have been looking this point for maybe we can say as 30 to 50 years. And as early as 30 years back, when the people dissected the aorta in the patients who are dying with acute kidney syndrome, actually they noted the people who are having acute kidney syndrome, the plaques in the ascending aorta were different from those people who died from stable coronary artery disease. Typically, these plaques have a higher foam cells, higher amount of lipid core, and a thin fibrous cap, but they had a less amount of smooth muscle cells. We know that the statins lower atherosclerosis. This has been known for the long time. So the question comes when we have new agents on the block, which we know are the PCSK9 inhibitors, and typically PCSK9 inhibitors can lower the LDL cholesterol 50 to 60% more than the high intensity statin can achieve, giving rise to typically LDL cholesterol levels of 15 to 20 milligram per deciliter. So the question comes to us, to all of us in the mind, if you lower the LDL cholesterol this much aggressively, what kind of impact you can have on the plaque morphology and the plaque composition as well as the plaque volume. Geographic studies, so the studies which were done by angiography long time back with the statin, they found that the degree of reduction in the angiographic lumen is in the order of few RBCs. So very minute reduction in the RBC in the order of plaque thickness. In addition, intravascular ultrasound showed that the reduction in the atheroma volume is in the order of few percentage. But the clinical data we all know, and the clinical data shows very clearly that if you give the patients high intensity statin, you can actually lower significantly the outcome in the patient with atherosclerotic cardiovascular disease, indicating that the impact on the clinical outcome is far out of proportion than can be showed by the imaging studies. Typically, in a data analysis of nearly 6,000 patients, what was seen that if you lower the percentage atheroma volume by just 1%, you can have 20% reduction in the clinical outcomes. So it appears that the intensive lowering of the LDL cholesterol modifies the plaque in such a way this plaque becomes more stable and becomes less likely to rupture. So how we can prove this point? For this we require newer tools, and fortunately over last 1 decade, 2 new tools have become which have become a commonplace to be used in the field of cardiology. One is the intravascular ultrasound, which is coupled with the NIRS. NIRS is nothing but near infrared spectroscopy. So what it does, it emits a radiation in the form of the near infrared spectrum and analyzes the light reflected from that and tries to look at the chemical structure of the plaque. So there are ways which we can identify and translate the information. More the lipid core, more the machine will encode as a yellow area, and less the lipid core, less the coloring of the circumferential area of the lumen of the coronary arteries at the red area. In addition, we have an optical coherence tomography. And optical tomography is characterized by a very, very high resolution. Typically, the resolution of OCT is in the range of 10 to 15 micron. And you can look at multiple characteristics of the plaque. Particularly, you can look at the thickness of the plaque. So you can actually make out how much is the plaque thick. You can look at the cap of the plaque. And there is data to suggest when the plaque cap is less than 65 micron, such plaque is more likely to rupture. You can look at the arc which is subtended with the plaque. More bigger the arc, more is actually density and the intensity of the plaque inside the coronary arteries. So the data which look at the intravascular ultrasound and the OCT, they showed that when you lower the cholesterol aggressively by using PCSK9 inhibitors, you cause multiple changes in the plaque. You make the thickness of the plaque much more robust. You decrease the arc which has been subtended with the plaque. In addition, you reduce the total amount of atheroma in the plaque, and you reduce the percentage amount of atheroma which is in the plaque, means more smooth muscle cell and the less the volume of the lipid core inside the plaque. So the number of data which have been shown in small studies which showed a remarkable benefit in the outcome, which we know is the missing link between the plaque stabilization and the clinical outcome. This data has been advanced by 2 new studies which came in the field. One is the Hyatt study, which is done by the velicumab, and one is a Pacman AMS studies, which is done by elucumab. So both the PCSK9 studies are the dedicated studies which look at this outcome, and the Hyatt study we will like to discuss first. It included nearly 161 patients across 37 centers across the world, and this looked at how does the evolocumab when given for 1 year modifies the plaque, and the researchers were able to show that the amount of LDL cholesterol came to an absolute value of 28 milligram per deciliter, which is very, very significant. Nearly half the values recommended by European Society of Cardiology of 55 milligram per deciliter. And this intensive lowering of LDL cholesterol caused a powerful impact in the plaque morphology. Typically, the primary endpoint for the Hyatt trial was the minimum fibrous cap thickness. This doubled up in the population. In addition, the percentage of thermovolume came down, and the arc, which is subtended by the lipid core, came down to nearly half in the population who received placebo. That means they did not use PCSK9 inhibitors and were on high intensity statin. Similar data came out from the trial, which included evolocumab, which is called the PAC-AMI trial, and they randomized the patient within 24 hours of doing the angiography and the NIRS and the OCT into the arm with evolocumab versus placebo. The evolocumab was used 300 milligram once a month, and what they were able to show, once again the similar finding, that the plaque become more stabilized. So what we have to do, we have to actually separate in our mind the plaque stabilization and the plaque regression. Plaque regression is a long-term process, and the impact is not seen for decades and the years. Even if it's seen by a short-term study, which we do at 1 year, 1.5 time, we can have actually only have a few percentage improvement in the plaque regression. But what the impact comes from the aggressive lowering of the LDL cholesterol is towards the plaque stabilization, a modification of plaque from the vulnerable plaque to stabilized plaque. And this means that the cap of the plaque becomes more thick. This causes the plaque to be sealed inside and less liable to rupture and less liable to cause thrombotic complications. So what we can say, if you lower the LDL cholesterol more aggressively, you can cause certain fundamental changes in the plaque. You cause depurification of the plaque, you cause the plaque stabilization, and you change the characteristic of vulnerable plaque to a more stable plaque. So we can actually say there is a game is over for the vulnerable plaque. We can stabilize the plaque by causing LDL cholesterol lowering. And at our hospital in Fujairah and the Amrish Health Services where I am working, we are having a very short, we can say, a fuse to start the patient on PCSK9 inhibitors. Typically 50% of the patients who are having acute kidney syndrome or cerebrovascular event, they are on PCSK9 inhibitors. And it is not at all surprising to see patients come to the clinic with LDL cholesterol of 10 to 15 milligram per deciliter. This doesn't bother us at all, and we continue, and we are seeing the consequences by using PCSK9 inhibitors over 5 years, that the amount of readmission rate and amount of complications in these populations have come down dramatically. So ladies and gentlemen, I conclude the talk by saying 3 things. First of all, we have to lower the LDL cholesterol by any means. A high intensity statins can do the job, but they cannot do the job in all of them. We have to take the help of PCSK9 inhibitors and the inclisiran, which is now introduced in clinical practice. More we lower the LDL cholesterol, more we actually cause stabilization of the plaque and the delipidification of the plaque. And the third and the last point, this translates into meaningful clinical events as shown by the imaging study by the Hyatt trials and the PAC-AMI trial. Thank you very much.